This was a case that was developed by the ALL Hub team, and I have a couple other cases in mind that we could maybe discuss at the end. But the idea here is what to do potentially to get a patient to CAR T cell therapy, to try to think about moving potentially CAR T cell therapy earlier into treatment, although this is really a relapse case. Next slide. Go ahead. These are my disclosures. Okay, so the patient is 42 years old, diagnosed with Ph-negative BALL, received frontline therapy with hyper-CVAD, fractionated, relapsed following frontline treatment, and the hope is to get this patient to CAR T cell therapy as first salvage therapy, rescue therapy. Next slide. And the question that was posed was, what are the therapy options to induce a remission prior to CAR T cell therapy? I would propose that one doesn't necessarily have to achieve a complete remission to go to CAR T cell therapy, since that's the whole point of CAR T cell therapy, is to induce a deep remission. But be that as it may, we'll move forward with the discussion. So the idea was that presumably this was a CD19 positive ALL, as almost all of them are with BALL. And this patient also presumably had CD22 expression, which is also present, of course, in the majority of precursor BALL patients. And so this patient was prescribed inotuzumab as a potential, well, in my mind, a bridge to CAR T cell therapy. And the questions that were posed were, what is the optimal use of INO to induce a remission? How many cycles do you need a remission is my question, really. What should be monitored during therapy? And what are your strategies following CAR T cell therapy? In other words, is one using CAR T cell therapy as a bridge to transplant, or as a standalone therapy? Yeah, André.
Yeah. Thanks, Wendy. I just can tell you what we do at the moment when we use INO. So we try to use the less possible INO, which means that we tend to realize a bone marrow assessment every week. So if one infusion is enough, we give only one infusion, because the remaining problem is also to eliminate the normal B-cell compartment. And we have had some patients where we had no CD19 from the blast, but no CD19 from the normal B-cells. So we had to wait for having some target for the CAR expansion. So let's say, I'm not saying I'm telling the truth, I'm saying our attitude is to use the less INO possible and to strictly monitor the B-cell mass by doing either it on blood or also on the normal B-cell compartment in the marrow, which is kind of tricky MRD, if you want, to try to find the B hematogones. And then we decide when to do the CAR. And
interesting.
For your, and I'm open, of course, to the observation of our colleagues. And I will answer your second question afterwards.
Thanks. That's interesting. I have a question for you for later about that. Other comments or questions? Okay. So, André, one quick question. Is your goal then just to get a significant reduction in the disease burden, or is your goal to really get them into, well, at least a leukemia-free state by your measurements?
You obviously know that nobody knows the answer, but Nicolas and I have done a work which is not perfect, but we tried to see if it was the same to obtain a low disease burden with intensive treatment or with a low intensity treatment. And in fact, if for obtaining a low disease burden, you need a very intensive treatment, then your prognosis is more linked to the aggressiveness of the disease than to any level of residual disease. I do think that one of the difficult questions in the CAR T cell area is how to evaluate the aggressiveness of the disease. And doing a low intensity bridge is one way to address this question. Then it helps to decide what you will do after the CAR. Because if the disease is a really aggressive one, then it puts your patient at risk of relapse after the CAR, whatever the MRD you obtain after it. So for your last question, what we do, and I'm sure you do the same, is that we monitor very aggressively the B-cell aplasia. Aggressively means that some patients, we monitor it every 15 days.
Wow.
Because we are very anxious if they lose B-cell aplasia in the first 3 months, particularly. And we tend to monitor MRD every month in the marrow for the first 3 months. And then it depends on the genetics of the disease. Some we do it every month for 6 months. Some we are more relaxed, let's say.
Interesting. Okay. Well, that's really
Nicolas is want to intervene and say that I'm totally wrong.
No, absolutely not. I think we are working together, so I totally agree with what André said. Just if I can mention, because I'm just at the frontier between T-cell and breakthrough cell, all what André is saying is about persisting CAR T cells, and it depends, I think, of how you treat your patient that receive either breakthrough cell or OB cell. I don't know what you have access to, or any other academic CAR T or in development CAR T. And I think that's all what is André mentioned is about the opportunity to have a persisting CAR T. But if you use a breakthrough cell for this, or for instance OB cell, if you use breakthrough cell for these patients, I think it's something quite different. And even if they published about remarkable median overall survival, you expect to have a short persistence and in most of the case a relapse. And so it's perhaps a different way to lead with the post-CAR T intervention.
Thank you. Yeah, we could talk a little bit more maybe about this, because I think this is a big controversy, at least in my mind, about next steps after a CAR T. And I think you're right. I think maybe, I don't know, it will depend on the type of CAR T that is being used. Okay, next slide. So this is from the Obe-cel, the Felix trial. And this is the fast on, fast off CAR T that was just recently approved here in the United States about 2 weeks ago. I don't know what its status is in Europe at the moment. Is it also approved there? Not
No.
yet.
Perhaps in 2025, but it's not done
Not
so far.
yet. Not yet. Okay. So this was the trial of Obe-cel, which is an autologous CD19 CAR T cell product. Its potential advantages are that it is a low affinity, low avidity CAR T. And so the idea is perhaps there's less CRS, less toxicity up front, and potentially less T cell exhaustion, so more durability. So patients could receive bridging therapy. That's what we're talking about, with or without inotuzumab or kinase inhibitor or single agent INO, or you can see all the possibilities from the Felix trial. A total of 127 patients received the product. 14% of them, 18 patients, received bridging therapy with INO, but the majority received bridging therapy without inotuzumab, and a few of them just went straight to CAR T cell therapy without any bridging therapy. And you can see that the percent of patients who received bridging therapy with INO had the highest blast percentage going into the bridging therapy or going into the CAR T cell therapy. Next slide. And these are the results. And this is the number of really the CR rate and the number of events that occurred after getting the CAR T cell therapy. So, and you can see that the CR rate, even in the patients with bulk disease who got inotuzumab, the CR rate was very high, 83%. It was also very good in the patients without INO. They had slightly lower, quote unquote, lower disease burden. And the lowest disease burden patients who went straight to CAR T had an outstanding 100% response. And you can see that that then there are some differences, that the duration of response was better for the patients with more disease who received INO than those who did not receive INO. And you can see the event-free and overall survival, which in the patients with low burden disease has not been reached. And there's a small number of those patients. So this is all very small numbers, except for the bridging without INO, where there were 100 patients, probably a better sample size. So you could see the number of events in the bar curve on the right, that there were actually quite a few event progressions in the patients who got CAR T, obe-cel, and did not receive INO bridging, versus a relatively small number who had bulk disease but did receive INO as bridging therapy. Next slide.
Wendy, can I just ask a quick, I mean, I know it's just a tiny number, only 9 patients. If we go back to that previous slide, but
yeah,
the no bridging looks
outstanding.
What's the best of all? I mean, just 9
yeah,
patients.
they had, as you saw from the previous slide, those are patients who probably, and I don't know, I need to go back and look myself, but on the previous slide, it showed the disease burden, and you could see the median blast percentage was lower in those patients, but still it was 20%. Okay. So they were patients with less disease burden to begin with, but still.
Gotcha. And also they are the less aggressive probably if they can skip the bridge.
Exactly.
Yeah.
It comes back to what we said earlier.
Exactly. I think there are so many factors here. And these are patients who might just, exactly. So it's hard, but so potentially it's really the disease biology that dictates the risk, the durability of the response. It's sort of what you were alluding to earlier, André. Next slide. You can go to the next one after this. So, so these are the considerations for using inotuzumab. Obviously CD22 expression is key, but it is easy to deliver. You can deliver it quickly. As André said, you can actually check. It's given weekly ×3 each cycle on a 4-week basis. So one can check actually response. And sometimes, as I think André was suggesting, responses to INO are extraordinarily fast. And with minimal amount of exposure. At least that has also been my experience, that often just one dose, the patients look like they're going into, we don't actually check, but they often look like they're going into remission. So the advantages are that there is high activity, regardless of the disease burden. It's safe, relatively so. It can be I think the safely combined with chemotherapy remains to be determined, but it can be combined with chemotherapy. And it can be given as an outpatient, actually. We often give it as an outpatient. The limitations to using it as a destination therapy, we all know this from the INNOVATE trial, is that there's a limited remission duration in those patients with relapsed disease who do not go on to some additional therapy. And of course, the risk of hepatotoxicity and veno-occlusive disease, sinusoidal obstructive syndrome. Next slide.
Wendy,
Yes.
I am not fully convinced that the activity of INO is the same in all genetic subtypes of ALL. For example,
I agree with
for
you.
KMT2A rearranged ALL, I think that INO is not effective or it has poor effectivity.
I think that's true. I think that absolutely disease biology impacts all of these treatments, Blina as well, and CAR T cell as well. And I think that was sort of what André was saying kind of at the very beginning, is that we need to really sort of understand who are the subsets who benefit from this. But you're absolutely right that the KMT2A, that many of those patients don't even express CD22, or at least some of them don't, in my experience. And so, because it is a very primitive, early sort of, myeloid-ish cell.
If I just can add, we recently published the EWALINO study in more than 200 patients in GCO. And what we have shown in this study, it's about elderly patients, but that high-risk patients with KMT2A, with hyperdiploidy, and frequently related to TP53 mutation, they do not respond that good in terms of response and also survival to inotuzumab combined with low-dose chemotherapy.
And we've shown exactly what Nicolas mentioned in relapsed refractory setting. Low hypodiploidy, TP53 mutated, and KMT2A do not do well. They came to the area-rich disease. On average, they have less than 70% expression of CD22, and it can go up to 10%, and that limits the use of inotuzumab no matter what dose we use.
Yeah, I find the exact same thing. Actually, that's the case I wanted to discuss with you guys, if we have time. Okay, so here's the question, and maybe André, you could give us your opinion. This is the standard dosing of inotuzumab from the INNOVATE trial, and this is the standard dosing in relapse setting, 0.8 mg per meter squared on day 1, and then 0.5 per meter squared on days 8 and 15 of a 21-day cycle. This is the slides from the INNOVATE trial. In my opinion, which I put down there, you can give up to 2 cycles, but for CAR T, perhaps 1 cycle only, or even less, as according to what André was saying, the minimum amount needed to get patients to CAR T in this case. And I don't know, André and Nicolas, if you do you use the standard dosing when you give this as a bridge to transplant, or do you use lower dosing?
No, we use this dose, which means that if we give 1 dose of INO, it will be 0.8, and then the subsequent dose will be 0.5, sorry. But what we have seen in a few patients, that only after 1 dose we get to MRD negativity and prolonged B-cell aplasia, even after 1 dose on a patient with more than 100 white blood cells. So some patients have extraordinary response to INO, and whatever you go to CAR or to transplant, I do think that the less you give, the best it is. Obviously, it forces you to be aggressive in terms of marrow aspiration, because you know that in Europe, we do not do biopsy. We do marrow aspiration, which is easier to repeat every week. So this is what we do. So some patients have 1, some patients have 2, some patients have 3. It is exceptional that we give more than 1 full cycle of 3.
Right, I would say the same. I mean, in terms of the number of cycles, I haven't done as innovative as you have in terms of checking after a single dose. But I think in general, less, of course, less is more. And we know that because many of these people will eventually go on to transplant. At least that's my approach. And you want to minimize the exposure of inotuzumab to the patients going on to myeloablative transplant. Next slide, excuse me. So these are just the modifications for use of inotuzumab. I don't think we really need to go into these things. This is pretty well known as certainly by this group, but good to have. And, you know, what we're looking for are really, in my opinion, to optimize treatment. And as André was saying, and Nicolas, what the most important thing is to try to minimize toxicity by reducing disease burden with minimal toxicity. So all of these factors need to be considered, including tumor lysis potentially. So you need to definitely prophylax these patients with explosive disease, which gets back to the point of the ones that probably did the best are the ones with sort of smoldering disease, who didn't really need any kind of bridging. Next slide. Of course.
Don't you think, Wendy, that TLS is always a good news?
Yes, I do think it's always good news. Absolutely. So we have to be prepared for it and kind of hope for it. True.
Be prepared, but good news.
Yes, true. So, and then MRD monitoring, for sure, we know that outcomes are best if you have MRD negativity. And we know even from the earliest CAR T cell therapies that were done in adults, the data from Jay Park at Memorial, that the MRD negative patients who were MRD negative going into the CAR T and who achieved continued to be MRD negative had the best durable responses. So of course, it is nice to get that happy medium. Next slide. I just put this in because my goal is to cytoreduce patients. I would love it if they were MRD negative, but really to minimize toxicities to allow the successful bridge to CAR T, because the last thing you want is to give intensive therapy and then have the patient so sick that by the time the T cells arrive, the modified T cells arrive, the patient's too ill to receive it. So it is sort of a kind of like a Goldilocks thing, not too much, not too little, just right. So these are some alternative options that I know have been used as bridging therapy. I just list them here. I think it's also important to remember to give intrathecal therapy as part of the bridging therapy. You do not want, we know that the T cells can penetrate the CNS, but certainly you do not, in my opinion, wouldn't want to go into CAR T cell therapy with overt CNS disease. And that actually was excluded on the clinical trials. Next slide. What are the management strategies following CAR T cell therapy? Well, we know that all of these factors are very, very important. We've learned a lot in the last 6 to 8 years on management of some of these very dramatic effects of cellular therapy. And I won't go into detail on all of them, but you know, in my opinion, just from attending on our cellular therapy service, the patients who get the worst of these effects, myeloma, lymphoma, are the ALL patients. This is just an explosive disease, and we see a lot of these toxicities and are now in a much better shape to manage them. I don't know if other people have opinions about this. There have been newer data suggesting earlier intervention with steroid, earlier intervention even with some of the cytokine inhibitors, tocilizumab, and even anakinra, to try to minimize the severe toxicities that are seen once the CAR T cells are there. But sort of like the tumor lysis, it's probably a good thing to see a little bit of that because it suggests that, of course, the T cells are expanding. The next slide. This is a management slide of CRS and ICANS. I think it's really good for the, for the audience. I think it's changing pretty frequently. These are relatively recent recommendations for management of CRS and management of the neurotoxicity, the ICANS. I won't go into detail, but most centers now have very specific protocols for managing this, and it's become a much more readily more comfortable, even though it's stressful situation. So my question to all of you is, and I'm just curious, I want to know whether, and this is sort of something we started with, is presuming that this patient enters remission, this patient got, we don't have much experience yet, except from the Felix trial with obe-cel. We have more experience in the real world with Brexucel. And the question is, do people in a patient like this, first relapse of ALL, do they take them to transplant immediately, ever, wait, etc.? My approach has been, in general, because every one of my patients has relapsed, whom I haven't taken on to transplant from the original data, is to transplant them as soon as the CAR T toxicities resolve. That's been my approach if they're transplant candidates in this setting. In patients who've already had a transplant, I think that that's a separate discussion. But I'm curious to hear what other people are doing and whether you think that will change now with the potential, well, in the United States, the definite availability of obe-cel, and soon in Europe.
So I have few cases, but in general, let's say Italian option is to transplant them, at least if they never received the first transplant. If they already received transplant, the situation gets more complicated for several reasons. But in general, we try to transplant them. And regarding inotuzumab, before CAR T, we try to give one cycle, just to reduce the burden.
Thank you.
I would tend to agree, to avoid relapse, which is a major problem. So go to transplant especially in a relatively young patient like yours. And personally, I don't think that obe-cel will change the algorithm all that much. It might have the advantage of lowering the toxicity that you have in the patients going into transplant. So it might actually be an additional benefit.
No, we try not to transplant the patient. We follow the pediatric recommendations for young patients, and I think that so we did not treat any patient with obe-cel so far on the T-cell up to 25 and axi-cell. So again, I think that obe-cel for patient older than 25, we change the game in terms of criteria to transplant after obe-cel in first relapse. And and the other thing that we will probably have to care about is wider exposure to blinatumomab frontline, and how it will modify the expression of CD19, of course, at relapse, and how it will modify also the results from the Felix study. It's it's of course something I would consider to decide to transplant or not. Prior exposure to blinatumomab, MRD at day 28, and persistence. But,
Thank you.
André, you had a question? Comment?
Yeah, it's more provocative question to Wendy.
I think you're going to ask what I'm going to ask. Go ahead.
If
do you really need the CAR T cell?
No, if the CAR T are only a bridge to transplant, I have a problem with CAR T.
Me too.
Okay,
I do too.
They are so difficult to implement. They are very expensive, etc., etc. So, and we have now at least Blina, and in the next times probably Super Blina coming, etc. And same for ADCs, which will be much easier to handle at some point. So if the CAR T is only a bridge to transplant, there is no future for CAR T. If the CAR T is a standalone therapy, then I'm interested in CAR T since 10 years now. So the big question is about persistence and, of course, clonal escape. If the possibility that we have a better CAR than the current one, which is Kymriah, in terms of persistence, if we have the YTB, for example, or whatever, then the standalone therapy is something. if all of you consider that CAR-T must be followed by transplant in most of the cases, then let's forget about CAR-T. Just a provocative assessment.
No, that is exactly the question I was going to pose. That is actually my whole problem with at the moment with CAR-T in the relapse setting. And there are very few patients actually, because of my experience with the CAR-T, where I don't take the patients to transplant. And therefore, why not just give the inotuzumab, get them into a remission or blinatumomab, what have you, and then go to transplant without, you know, you need to get a deep remission there if you want to take them to transplant, but it's very possible with some of these targeted immunotherapies. So I agree that this is a conundrum, and there aren't that many patients. It's very difficult, as we all know, to get patients to CAR T-cell therapy in this relapse refractory setting. And so the question really is, if we're going to develop this technique or this strategy, should we be doing it early and using it as definitive therapy, as I guess that's what you're trying to do in France, in your group? But we haven't yet done that. There are some early studies going on where patients will get this as frontline therapy or sort of definitive therapy. So I think it's really an interesting topic, and more to discuss potentially in the future. And so
thank you for anyway for sharing with us these questions.
Yeah.
Very interesting.
Yeah, thank you so much, and really appreciate all of your opinions and thought and time.